Well, good evening, everyone. Thanks for making time out from your evening family and other work or clinical activities to join us for tonight's webinar on the voluntary assisted dying process and pathways and some of the experiences that have been derived in WA over the last few months since our process has been operational. So we have a great panel tonight who've come from all aspects of the VAD process, and I'll run through names and I'll allow each of them will then tell you a bit more about their role within VAD once they're ready to start talking with you. Now, if you have any questions on the right-hand side, or hopefully on the right, there'll be a field where you'll be able to post questions. I'll be monitoring that while people are talking to you about their role and activity. And if questions come up, then I will direct those to the panelists once they become, once they're posted up there, or as soon as we can. So feel free to ask questions, and it often helps because then we can put them into the discussion as we go when it's immediately relevant, rather than delay things till that awkward, oh, when do we talk about that? Oh gosh, feeling at the end. So please post your questions as we go along, and I'll direct those to our presenters, and then they can say, yep, I'm going to cover that later, or yeah, great idea, let's talk about that now. So first on my screen tonight, or first speaker tonight, is Alice Herring, who's the Statewide Care Navigator Service Officer for WAVAD. And behind Alice, she has the most beautiful life transition tree, which she will explain in more detail. So this has very strong symbolism for the palliative care and VAD movement. And second is Fiona. Fiona Jane works in the Albany Community Hospice, and she's had a great time working there, and she's very keen to tell us about some of the lived experience of what is going on in that area, and some of the issues that have come up and how they've addressed them. The next person on my screen is Brenda. Brenda Schum is the VAD statewide pharmacy guru, and she helps to provide and dispense and organise all the placement of the various medicines and things that have been used throughout palliative care and also within the VAD process. So she'll be talking about that in more detail for us. And Gareth, hiding behind a false screen of exotic bottles, is an emergency physician working at Charlie's, St Charles Gardner to be more formal, and he is one of our VAD providers. So he'll be talking about the perspective of working and as a GP in that area. And at lucky last, Scott Blackwell's finally made it onto the screen. Thanks for joining us, Scott. Scott's, as you will see, a lovely experienced GP, a long-standing GP in WA, and he's the chair of the Voluntary Assisted Dying Board. So he's been intricately and intimately involved in so much of the planning and the administration and the legislative work that's had to have gone on to enable this process to happen for our patients and maybe even for ourselves. So the order of speaking tonight is Scott first, if he's ready. So are you ready, Scott? When you've unmuted, we'll be able to hear you.
Can you hear me now?
Beautifully, thanks, Scott. It's lovely and clear. Good. Over to you.
Good, thank you, and thanks for that introduction. Somebody asked me the other day, do I still do some on-call? I said, well, I've been on call for about 50 years, and I guess that's a bit old-fashioned for general practice these days, but it's still where I'm at, I guess. I wanted to start just by telling a little story, really, and this is a story that comes from about 1500s in the UK, and I guess it wasn't the UK then, but it's a story about a man who's taking a walk from one village to another, and he walks into a village and he sees another man with a wheelbarrow, and in the wheelbarrow he has some bricks and some mortar. And he walks up to this man and said, "What are you doing?" And the man says, "These bricks are heavy. Can't you see I'm busy?" And he walks quickly on with his wheelbarrow. He thinks, okay. Walks a little bit further along, he sees another man with a wheelbarrow and some bricks and some mortar. And he says to him, "What are you doing?" And the man slows down a little and he says, "I'm building a wall." And off he goes. And our man walks a little bit further down and sees that there's a building site ahead, and another man comes by with his wheelbarrow, and in his wheelbarrow he's got some bricks and some mortar. And our man says to him, "What are you doing?" And he puts his wheelbarrow down and he turns to him and with a big smile and says, "We are building a church, and this will be a very important thing to bring our community together." And I start with that illustration because I think it really tells us a little bit about different approaches to different situations in life. And I tell the story for two reasons. And firstly, probably as a challenge to all those who are with us tonight, to think about what's your response to people in terms of their approach to you when they get into an end of life situation. Not thinking particularly of voluntary assisted dying, because I think many of us actually react in all three ways at different times in our life. But I think what end of life really needs is to be like the third man who looks at the whole global picture, sees what is good for that person, what is good for that community, what's good for the people around that person who's dying. And I just wanted to challenge you with that thought tonight, so that when people do address you on this sort of issue, that you can click into that mode of thinking, because I think that's what end of life care needs. The other reason that I tell this story is because through the implementation process, we had some interesting times. And, when the legislation was passed, then an implementation leadership team was formed with a very significant support staff from the health department. And we were given about 15 months or so to be ready for voluntary assisted dying to go live on the 1st of July last year. So there was some significant pressure, really, because essentially that was a legislated date, and that date had to be that date. But I think along the way, we did a lot of work for the first 6 months, and we put a whole lot of things into place: training programs, credentialing. We developed this concept of a care navigator who you'll hear from soon. And we talked about pharmacy, and we had everything in place, but we didn't have any people. And we were going into the beginning of 2021. I have to say I was a little apprehensive as to who would these people be. And I guess the first sort of breath of fresh air came around about March, when the Care Navigator process had actually been developed to a point where we were actually engaging people to be care navigators. And when I saw the people who put their hand up to be care navigators and spoke with them and got a feeling for the sort of person that they were, and they really were that third sort of person from that story. And I started to feel a little bit better. And then as we went further on, became very apprehensive again as we got closer to the date of starting, because who would the clinicians be? Who would the pharmacists be? And all these little things really started to put a lot of pressure on. And then some doctors were doing the training, and some doctors came through, and I met with them and developed the same feeling that these were those same people with that same attitude to end of life care, and particularly to people who ask for voluntary assisted dying, and the pharmacy group the same. And so I guess my point is simply this, that what is really making voluntary assisted dying work in Western Australia is in fact the people who've stepped up to fulfill the roles that are necessary to make it work. The legislation is good. It is quite well constructed legislation that we were able to work with. It does have plenty of opportunity for access to be allowed, for safety to be guaranteed. But the most important thing is the people. And that's what I'd like to say just as an introduction tonight. And I'll leave it at that too, for others to follow.
Thanks, Scott. It has been quite remarkable watching the growth of activity within VAD across WA in, as you said, in a very short space of time. And it's been really gratifying for everyone involved to see the huge response, or a groundswell of response emerging once the community and the other health professionals became aware of its ability to look after people in an extra way. So it has been quite remarkable watching that happen so quickly. We all know that legislation is a very slow process, but watching this activity from people has been remarkable. And I think you would agree, wouldn't you?
Yeah, very much so, yes. Yes, I think it has been quite remarkable, and it probably reflects on, I guess, the feeling we got from the people way back before the legislation that this was something that they really wanted, and I think we're now seeing that this has played out in reality.
Yeah, it's watching this social movement gain impetus and clarity has been quite remarkable and a great feature of our society. If there are any questions for Scott, pop them in the question box, and if not, you can certainly add them later, and feel free to direct them to any of our panelists even after they're finished presenting, because we will bring those questions into the fore for you. So our next speaker is Alice, and Alice, as I said before, is as Scott mentioned about the statewide care navigation service. Well, that's Alice. And so, do you have minions to help you yet, Alice, or are you the only person?
Oh, heavens no. I'm very lucky to have some marvellous, marvellous minions. I'm not sure that I'd call them that to their face, but they are deeply fabulous.
I'm only teasing. No, it's wonderful to have people to help, because I can see that this is a huge job, and particularly when we've got intricate legislation, intricate clinical pathways, intricate pharmacy pathways, and then all the legal pathways as well, and then the care for the family afterwards. So I'm sort of, hope I'm not stealing your thunder, but I'm just thinking of the breadth of work that's involved in your role, and I'll leave it to you now to tell us what you'd like to about that. Thanks, Alice. Over to you.
No worries. So I certainly am extraordinarily privileged to lead the WA VAD Statewide Care Navigator service. I think one of the tiny things that maybe Scott didn't think of was a catchy title for us during the implementation phase, because answering our phone is quite a challenge. But I am very, very lucky to lead a small but very dedicated crew of varied health professionals, some nurses and some social workers at the moment, to act as the primary point of contact for VAD across our state, whatever the need is. So I've been very lucky in my nursing career to have worked in multiple different health services in multiple different states and places, including the WA Country Health Service, and I've had some really unique, rewarding and challenging experiences in all the different positions that I've held. But this is like nothing else. There's nothing that I've done to date that holds a candle to the experience of working in this role and the people that we work in this role with. And I think it's beautiful to hear that from Scott as well, because absolutely the people make this. And in those people, they're the individuals who choose this choice or choose to explore this choice, perhaps not go all the way through the process, but to walk this path with us. And they exhibit bravery and courage in facing their own mortality in a way that humbles me every single day. Their strength, certainty and peace is something that I can come back to time and time again when logistics are hard, where timeframes are tight and demand is high and things are just seeming all a little bit too difficult and in the too hard basket. But those people are not the only ones that are involved in this journey, and certainly whilst there's a person making this choice, there's those that walk alongside them, all their loved ones, their friends, their carers, that step with them every single piece of the journey in what in many cases is absolutely impossible and heartbreaking for loved ones, but they are beyond extraordinary. The work is really challenging. And yes, I do have some minions and they are marvellous, but demand is high, and I'm sure we'll talk a little bit more about that tonight. But there is help along the way for everyone who's involved in the process, particularly from the Navigator service. So we are here to support patients and their families as much or as little as they need, always person focused and person driven based on what they're asking for us from us. We do everything from a single fact-finding phone call where people can call us themselves to finding practitioners for them at their request with their consent, caring for them through each part of the very sometimes complex process, being present with them when they die and providing that bereavement support to their families and loved ones after the fact. We're also here to support all of you in whatever capacity you're caring for patients in relation to VAD, and that can be big things or small things. It might just be calling us to talk through a case where you're not sure how to support your patient or what to do, or someone's made a first request of you and you can't find the flipping form and you don't know how to get onto that IMS to lodge it. Very happy to help. And we do at all times very much encourage and facilitate patients to communicate with their GPs, and we'll often do that on their behalf, recognising that in most cases the GP is the real cornerstone of that patient's healthcare team, and having you engaged and having you involved is incredibly important to making sure their journey is as smooth as it can possibly be, whatever their choices are. We also manage a particular fund. Gareth, who you'll hear from later, was very keen to make sure I mention the money. So we do have something called the Regional Access Support Scheme, which has been established to make sure that we can do everything we can to facilitate equity across regional WA. And for regional practitioners who are considering doing the training to support a particular patient where there are no trained practitioners available in your area, we can use this fund to recoup some of your time through lost earnings. So it does take you about 6 hours to do the training, so this fund will cover you for that time. We do also use the fund primarily for caring for patients where travel is needed. So if you're going to be willing to travel to support your patients and you're going to go over 70 k's from home, we'll fund your mileage. If you're going to fly, we'll pay for flights, accommodation and incidentals, but we also do cover, again, remuneration for time lost where you would have normally been seeing patients in a clinic or working in another capacity. Fee for your service is between you and your patient though, so this is all on top of that. And I would like to come back to the practitioners who have done the training and do choose to provide this care, because they are unique and extraordinary. Their capacity to provide careful, considered, compassionate care in such a person-centred and person-focused way is something that I've never experienced before in health. We talk about it a lot. It's often a catch cry that gets thrown around, but it is an absolute treasure to see it in real live action each and every single day when we care for these people and firmly putting them at the focus. We are lucky enough to support them in this. We answer questions for our doctors, we help them work through paperwork, we fact find, we witness, and sometimes we're just here for a chat and a bit of moral support. And I will stop chatting, but finally, the demand for this is real. So when I was first appointed and we started a regional roadshow before the 1st of July, we would talk to doctors about maybe at some point in your career a patient might raise this with you. It might come up at some stage, maybe have a bit of a think about it when you get a sec. I have to say that with demand far exceeding the initial modelling, I've changed my tune quite significantly, and I would absolutely encourage you to take some time about how you may respond when a patient raises it with you, because I think it's fairly safe to say that they will, quite possibly sooner rather than later, and quite often unexpectedly without you having any time to prepare how you might respond to that. So thank you all so much for making some time this evening to have a bit of a chat about VAD, and hopefully to have some things in your back pocket if a patient does raise this with you and ask for your help. That's it from me, Mike.
Alice, it's a complex field, isn't it? And what I'm pleased to hear on behalf of our audience is that your team will support us with all those awkward moments, the oh no, what, how, what, when, how, who questions that make such clinical practice sometimes so fraught, particularly when there's a lot of pressure under the, from the family and from the patients when they're the urgency of their situation is becoming more apparent, and we need the solutions quickly, but we don't know where to look. And so it's great knowing that your team is able to provide that for us in that setting. And more that we know that it sounds like it's a joy for your team to be able to do this. And so that takes away some of the angst and frustration that we may experience calling other departments who may be less enthusiastic about supporting us in the same work. So
We're always here, very, very much so, always here, and really always happy to chat, big or small, whatever it is that you need.
That's wonderful. Thank you, Alice. So, and again, Alice, you've wowed them, so there's no questions yet. So I'm sure those brains are thinking, and there will be something will come up shortly. I'm looking at the attendance list here. There's some noble intellects among that lot, so that should be coming up with questions along the way. And I won't name the noble intellects. We'll leave them to identify themselves. So our next speaker is Fiona. So Fiona's ready to join us in a moment. Fiona Jane works in the Albany Community Hospice, and a position that for those of us had the opportunity to work in a hospice, as you will hear, it's a wonderfully enriching experience. Even though it's tinged all the time with sadness and loss, there's a depth of richness which is palpable to those when we work in that field. So Fiona's going to tell us a bit about what happens in Albany or in the hospice setting. Thanks, Fiona.
Thanks very much, Mike, and to you too, Scott, and also to Alice, and thanks for the invitation to speak this evening to everybody. I'm just wondering if you can see my screen, because of course we've all just been playing with the brand new platform and no one quite knows, but anyway, let's give it a whirl.
It's lovely to see you. Thanks, Fiona.
Oh, that's good. That's good. Well, I'd just like to acknowledge the custodians, past, present, and future of the Menang Budja, on which I'm presenting from. And I acknowledge the knowledge and the culture that they share with us. And I think that that's very important. We can learn a lot from these custodians of the land who speak with spirit. So tonight I've been asked to speak about voluntary assisted dying in country, WA, and I'd just like to let everybody know that that's my dog. So she just thinks I'm talking to somebody else. Sorry about that. Albany Community Hospice is an 8-bed inpatient facility, and we've been going for 30 years now. Our mission is to be a leader in providing expert palliative care and end-of-life choices. And we would like to ensure that all members of our community can experience death with grace in a manner and a place of their choice. So some basic stats about us, you can read it there. We've got 40 employees, we've got 60 volunteers. We operate with medical governance from 58 credentialed GPs and specialists. So we're quite lucky. We have great support, and the Great Southern leads the way in the state, I believe, for really providing great end-of-life care. With regards to voluntary assisted dying, hospice had 8 first requests in the first 6 months. And of these requests, we had 2 practitioner-administered deaths at hospice and 2 in the community. You can read the stats there for yourself. I don't need to read the PowerPoint to everybody. But what we found was interesting in the patients that we assisted, the timeline from first request to administration was between 12 to 21 days. And that sort of depended really basically because the transport factor and the timing and weekends and public holidays, which I'll talk about a little bit further. So we had 4 things we wanted everybody to know about our experience with VAD in the first 6 months. And most importantly, we want everyone to be reassured that palliative care continues to be our prime focus. So regardless of a VAD request or not, We support patients in excellence in symptom control. We continue end-of-life conversations and supporting patients and their families along this journey. And what we've also noticed is that we needed to resource extra support within our organisation just to manage the processes of voluntary assisted dying. Initially, we had no locally trained voluntary assisted dying practitioners, which meant we needed to have a lot of contact with the Statewide Care Navigator, who helped us and arranged for trained practitioners to come to Albany. And this required temporary credentialing approvals. It required lots of communication back and forward between the practitioner and ourselves. And we sort of needed to get to know each other and build relationships. So there needs to be sort of one central person that facilitates that. Otherwise, all these messages get lost and the patient's left waiting, well, when's someone coming and, you know, when is this actually happening? So we've got one person who does that role. So that's been good. The other thing that we've actually seen is the use of telehealth, and we've used it mainly in the consulting assessment, just because we need to have a personal approach with a person for the first assessment. I don't think it's possible otherwise. And what actually also happened in our consulting assessments was the consulting practitioner had actually already met the patients before. They'd actually reviewed them as separately in a palliative care capacity. So the relationship building was easily facilitated, and telehealth didn't seem to impede that. It was a little bit more difficult when that relationship didn't already exist, but we always made sure that there was a palliative care nurse present and a family member present as well. So that sort of helped with communication and relationship building. And then we also noticed that there's been an increased attention to this preparation around the ritual of dying. And, you know, palliative care, we do this all the time. We support families in preparing for death. Families are involved in little rituals. But we noticed an increased sort of, because of the acuteness of knowing that death is going to be tomorrow, there were rituals around the day before death and the day of death that we found are quite unusual and have taken a bit of getting used to. And I just wanted to share with you a story about one of our patients that her experience taught us a lot. And this was a story of a woman who was a very accomplished woman and had only just moved from the city. And, you know, we hear these stories again and again, don't we? Retire and diagnosis. And this was the case with this woman, sadly. And obviously she had a very advanced stage 4 metastatic ovarian cancer, and she required all of this extensive treatment to manage her symptoms. But her main message was, things are only getting worse and I don't want to live this way. This isn't part of my plan. She was very much wanting to be in control. And so she made a first request to her GP, which unfortunately they were unable to help because they had conscientious objection reasons. But Alice and the Statewide Care Navigator team helped pair her with a trained practitioner who came to visit. And in the meantime, her GP continued to provide medical governance, and we managed her symptom control, and she and her partner remained at hospice and were both cared for by us there. So the assessment process began, and as you could see, there was we were needing to support not only the patient but also her partner. And luckily at hospice we can do lovely things such as put 2 beds together, and this is a beautiful thing and a very natural, normal thing, and that brought both Jean and Sue a lot of comfort. The first assessment was arranged and done in person with the practitioner who travelled from Perth, and this was a very affirming experience for both Jean and Sue, who had felt heard and that Jean's suffering was acknowledged. The consulting assessment was done by video conference, and as I mentioned earlier, the relationship was already established. So that made that assessment a whole lot easier. But there's always this processing when people get through one of the steps of the processes, that there's a relief and then there's a loss. And that requires really some sensitive support, that every person is different and you really cannot guarantee how it's ever going to go. But it's still just witnessing and honouring that process is so important. Processes such as the written declaration, we've been able to facilitate receiving that and witnessing that and expediting that process, which is more hoops that are jumped through. The one thing that we see with all of our patients at hospice when they do this VAD process is there's this focus on whether they're going to make it or not through the eligibility process, and they're also struggling with symptoms and management, and then ongoing discussions about the event of their death, which cause lots of strain in their relationships. And again, here is where family, friends, the clinical team, our allied health team, you know, anyone who's had a relationship with the people around them, all need support. So it's a moving platform. The final assessment again was done in person and a date was set. And this is another part of doing VAD in, for example, where a licence is a private hospital, we had to have clear guidelines on when this could occur. And this was tricky because you have to time it with a schedule of a busy practitioner and the care needs and also the deteriorating symptom of a patient, airline availability, and also the timing of the VAD process. So it is quite stressful. It's stressful for the staff who all want to see Jean get what she wants. And it's stressful for the patients not knowing if it's going to happen. And so it's a lot to manage, really. So what we actually found with Jean was that her symptoms began to escalate, and she was already on a syringe driver. But obviously the fear was around Jean losing competence because she needed more medication that would then alter her consciousness. So there was a discussion to reduce the dose level. And obviously, as I mentioned before, a palliative care symptom management plan was discussed and negotiated because we wanted her to remain in control. There were challenges, as I mentioned, in the clinical team with their own biased perceptions on what was right, whether to allow her to suffer and achieve her voluntary assisted dying goal or to give her pain relief and then for her not to get her VAD. So there was a lot of work that needed to support the team in this. The exit, the planning for leaving was very important for Jean, and on the day of her administration, she didn't want the syringe driver anymore. She chose favourite articles of clothing to wear that reminded her of her previously well self. She performed rituals that were meaningful and soothing to her and her partner, and had requested a group of close friends to form a meditation circle around the time of her death to send her on her way in the right way. So 20 days from her request, Jean died peacefully in her bed in hospice, facing the garden with Sue beside her and a couple of close friends to support them both. And they were both very grateful to all involved in their care and the ability to access VAD as an end-of-life care option to relieve suffering and be supported throughout the process. So that's it for me. Now I just have to work out how to do that. Thanks.
That's fine, Fiona. You've done. I think that's a beautifully moving story, Fiona, but it also exemplifies the complexity of the process and also the interaction of all those who are grieving at the same time as they're preparing to die. I think the key phrase that springs to mind listening to this story is about the sense of anticipatory loss,
Yes.
knowing that someone's going to go rather than the tragedy of losing them. It's sometimes a two-edged sword to have anticipatory loss or the ability to go through that feeling rather than have only the sense of direct loss rather than anticipatory loss. And that's a very complex area. And your story exemplifies that very well for all of us who are faced with patients making those decisions. And it's just lovely to know that that is going to be more available to people throughout our state because of you and others and the efforts that have been made to bring this about. So yeah, thank you for telling us that story and also exemplifying the complexity of the process at, at the coalface for us. And even more difficult, or as difficult in smaller rural sites as it is in a large, comparatively large palliative care hospice centre. But the same processes I've seen work in small country towns where the loved ones and the health workers have been on side supporting the process. So it doesn't require a huge team, it requires that the team be big enough for that patient in that environment. And that's where we've got the advantage of bringing in our cavalry from the VAD process and from palliative care to bring in the cavalry to supply the numbers that are needed for that patient at that time and the functions that are needed for them. So thank you for that beautiful story. Again, Fiona, you've wowed them. There's no questions yet. I'm sure they're saving them up for the end.
That's good.
Move on to, and I think there's going to be a little onslaught at the end if people are not, but I think you've enumerated the things so clearly that I think we're going to be meeting with good, clear questions if they emerge. And thanks. So now I'll move to Brenda. Brenda Shum is the VAD Statewide Pharmacy Service Coordinator. And Brenda gives out the goodies and helps us all with both the palliative care and with the hospital stuff. And in a sense, it's a very difficult role sometimes, even more difficult conceptually for some of us who've involved with patients' dying process and, offering medicines that we've teetered on the border of whether we've gone too far, whether we've given too much, how much can I give knowing that this is all right. Those sort of things are tricky, and now that we do have a defined pharmacy pathway, it's making those decisions a lot easier. And so Brenda, thanks, over to you and your experience of this process.
Look, thanks, Mike, for that beautiful introduction. Look, I think Fiona's story, I think the themes that Scott and Alice have brought up in terms of the people, that particular story about that patient as well, is why, we do these roles. It is challenging work. I won't, I won't say otherwise, but it's hearing stories like that, being able to provide this end-of-life care option for our patients, which make it, absolutely worthwhile, make it an absolute privilege to be in these roles and provide these services. So like Mike said, my team are responsible for maintaining basically all aspects of the VAD substances, and we have multiple. We do have a number of legislative restrictions, so we aren't able to disclose the names of these substances. If there were any questions about them, and often there are questions about them, but my team provides support for practitioners, whether or not they're the administering and coordinating practitioners, clinicians looking after the patient in whatever environment they're in, family, friends, carers, and obviously the patient themselves in all aspects about the substances. We are similar to Alice. We have a small team based in the metro area, but my team are committed, and we have travelled all the way up to Broome and all the way down to Albany, and multiple places in between to provide our services to those cohorts that I just mentioned as well. I think the thing particularly that I wanted to touch on for this group as a rural community is what we've seen time and time again, which is, both metro and rural practitioners and their commitment to patients, particularly facing some of those quite logistical so those numerous logistical challenges that Fiona spoke about, but also some of the restrictions that we have with some of our, national legislation. A number of aspects about VAD cannot take place through telehealth. So in terms of communicating, like I said, information about the substances, the prescribing as well of the agents, because of those restrictions, we require a handwritten hard copy prescription, which is really challenging in a state as big as WA, because what we found, even though VAD is is defined as a pathway that isn't considered an urgent, intervention, is that by the time, particularly when my team see patients after that length of time for the assessments, the information gathering, the decision-making process, the patient has changed in their condition such that it can become urgent. And particularly with our rural patients, some of the limitations that exist in our current COVID state, flights, timing, in terms of facilities, etc., it can pose a number of challenges in terms of getting that substance to the patient in time. And it's like you said, Mike, there is that anticipation, there is that level of anxiety that causes for practitioners, for our team, obviously the patient and their families as well, which is something we're still working through and trying to manage. It's been really wonderful to be working with the practitioners that we have to date to be able to provide that service to our patients. One of the things that we espouse as well is that our formal sort of involvement happens at around the last few steps of the VAD process. So some of you might have seen that snake diagram outlining the key steps of the process. We come in at the prescription, writing phase, but we are there at every step if you have any questions at all that you want to raise. Sometimes there's questions in regards to the prescribing process itself. I guess one of the things that we want to reiterate to all of our clinicians is that, not to hesitate. If you have any questions or concerns, please feel free to pick up the phone, send us an email, and we're always there to help.
Thanks, Brenda. Yeah, you're the guys who are helping us out so much, and I think it's important also that we have that as to be aware that there are legislative rules around the substances that we have to respect, and we have to work through or work with the secrecy components of it, and I think that there's good reason for that. Otherwise, our legislators wouldn't have gone to the trouble of making sure that they're built into it.
Sorry, Mike, I just can't hear what you're saying. It might be my connection at home.
Thank you. I might have lost some connection there. Just to say that thank you for making it clear that the support pathways are there for those of us who are prescribing to comply with the legislation, and also to get the clinical and pharmacology support that we may need to make the decisions that are involved. So thank you for making that so clear. And also to be aware, just to remind us of the secrecy provisions around the names of the substances that are used, that they're not for public disclosure. And with good reason, that's a legislative requirement. So thanks. No questions for you that I can see either, Brenda, at the moment. I'm trying to get them to come up. Here we go. We have a few questions. I'll just bring them through now. So Alison Bell has asked the team, how many people have access to VAD in WA? And Scott, maybe you would know, how many people in WA have access to VAD so far, and how many were expected in the modelling? I think we hinted at that the numbers were vastly bigger than we expected at first, but maybe you'd have some real figures for us.
Yeah, we work in a fairly confidential environment with numbers, but I can, and we generally need to wait till the Minister makes them public. But I guess the figures that are public at this stage tell us that we're running, we had 50 deaths in the first 3 months, and remembering that that included July, which was very much a run-in month. And to extrapolate that, we're now headed into the 120 plus sort of time, and that involves over 400 individuals making a request for voluntary assisted dying in the first 6 to 8 months of voluntary assisted dying in Western Australia. Obviously, some make a first request and then don't proceed with it. Others lose capacity along the way. Others get to the point of having a prescription provided, but then just have it there just in case the going gets too tough, and if it doesn't, then they die naturally. And in essence, I think our numbers are running a little similar to what most jurisdictions do, in that of the number of people that make a first request, you'll find about a third don't follow the process through, and another third probably drop off along the way, either because of capacity or choosing not to actually take the medication. So we're running fairly much along those lines. If we look at Victoria's figures, we were thinking that we'd probably run reasonably in line with them. Then we would have expected 50 people to access voluntary assisted dying and die from taking the substance in the first year, and we 50 to 60 or 70 maybe even. So we're running at about 3 to 4 times what was the predicted rate based on what happened in Victoria to start with. So yes, it is a very popular choice in Western Australia, and hence, as you heard from our speakers, a fair bit of pressure in there.
Thanks, Scott. A comment from Ruth Young saying to the team, thank you for sharing the story, Ella and Fiona, and I'm sorry, it's just gone off my screen. Ruth saying, thanks for sharing the issues regarding symptom control and being able to complete VAD, and it's a valuable experience to hear your experience and to recognise the challenge. There's a comment from Fiona to us. The next one, a more process question from Sue Douglas, a series of questions which I'll go to a little bit further, because I'll read them out because they may, Gareth may be able to talk to some of those, and if not, we'll come back to the panel. And so the questions are, how do we contact the Navigator? How do we establish eligibility? How do we find out if there's a credentialed clinician in our area? And how do patients contact the Navigator to ask their questions? So there's some process questions that we will address before the night's finished, and I'll have them up so that if anyone needs refreshing, we can go through those. So I'm just going to see if there's any more questions. Okay. And one from Helen Rawlings says, I've worked in small country towns as a remote area nurse where PAL care has not been possible due to lack of resources. I'm assuming then that VAD is only available to people who are able to locate to a regional centre. Perhaps we could talk, Scott, you might be able to talk about what, and Alice, Alice is saying that's a big no-no, that the field is much better than Brenda, than Helen has experienced. Alice, perhaps from your Navigator perspective.
Yeah, it's almost a reverse inequity, actually, in that in many ways we've worked really hard to make VAD as accessible as possible, and sometimes that means it's more accessible than some other services, particularly using the Regional Access Support Scheme. So we certainly have and continue to pay for practitioners to travel to a patient wherever they are across Western Australia, if there's no practitioners available locally for them, and the person and a support person, if they're well enough, can also travel to a practitioner if that's more appropriate, depending on their care needs and what else is happening for the person at the time. Very similarly to the statewide pharmacy service, the Navigator service travel wherever it is that we're needed to go across Western Australia. So we'll go and see people in their home to have conversations about VAD in Warburton or Kununurra or wherever it is that people need care and support in this space. So absolutely understanding there are some really big challenges in palliative care, that there are a number of strategies that are trying to address across our very vast and diverse state, but we are very grateful for the supports we have in place for access to VAD.
Thanks, Alison. I think that highlights the wonderful strength in this structure that we've got in the VAD process, and the strength of its organisation, that it's the inverse of the current model of care, which is that everything goes to the practitioner. That here we've got the opposite, where the practitioner, where needed, goes to the person. So in a sense, this is the opposite paradigm. So it's wonderful to be able to know that and to tell that to people in our own areas, to say, look, this is the opposite, that we can get people to come to you rather than you have to drag your way through all the pain to go and see someone else who you don't know necessarily to get support. So it's lovely to know that that's the reverse. In fact, it's the rediscovery of the old principle of medicine, isn't it, Scott? From even well before our time.
Indeed, it is actually. And yes, with the
horse.
Yeah, I think we've tried particularly to build this from the beginning with and I suppose if you think about the legislation, essentially what we started every meeting when we were doing the implementation phase, and what Alice's team and Brenda's team and the clinicians and so on have all carried on with, I guess, is the understanding that each case we are dealing with a West Australian person who has an illness that is going to cause them to die in the near future, and who is suffering in an unacceptable way to them. And if we keep starting at that point every time, then we create the sort of service that we've managed to create, and the people to do it have emerged, as I said earlier, and that's been probably the greatest joy for me.
Yeah, and I agree, Scott. That's the wonderful thing about this, is that it's perhaps the most, other than maybe, it's probably unfair to draw a comparison, but along with palliative care, it's one of the most patient-centred processes that we have in the provision of healthcare, particularly at a government level for the financial support, but also at the individual and the process level. So it's there and it's patient-centred. So hooray! That's a nice change from what we're used to from other departments within government. I didn't say that. Okay, now a comment from Megan Luck. Thanks, Megan. From a pharmacist's point of view, the disposal of any unused or unremaining VAD substances, is it carried out by the VAD pharmacy service, or is there some other process or person involved in the disposal where relevant? So that's a practical question. It's the aftermath and the mopping up of the materials, really. We've been talking about the people all the time, but this is more about the materials. Alice, maybe you can help us with this, or Brenda.
Yeah, so with our legislation, this is the great thing about our legislation in terms of its difference with Victoria. So with Victoria, it does require the statewide pharmacy service to destroy it, and any unused substance to come back to the statewide pharmacy service. But, you know, Scott and everyone who was involved in building legislation had the amazing foresight to understand, you know, our geography is just so vast in WA, and that's just not feasible. So there are specifically named more senior pharmacist positions across both the primary care and tertiary care setting that are permitted. to destroy the medication. So for myself, for example, myself as a chief pharmacist or one of my deputies are permitted to destroy the substance according to the legislation, and that's any deputy or chief pharmacist at a hospital site, for example, or a manager in charge of a community pharmacy is able to do that. And with the VAD substance kits that we provide information in the kit labeled specifically for an authorised disposer. We've also got that information freely available on the Department of Health website as well.
Thanks, Brenda. And this question also comes to you as well. And then Gareth, waiting patiently in the wings. We'll be with you in a moment. A question from Gay Fisher for you, Brenda. Is there any situation where the medication is held by a local health service on behalf of the patient rather than designated support person? I think that may also apply in some of the more remote areas, or where there's some communal, lack of communal responsibility is evident, where there's dysfunction within the normal community, where that might be a problem. So is there anyone else other than the designated support person that can hold the medication? Thanks, Brenda.
Yeah, look, that's a great question. So our legislation requires that the substance is in the possession of the patient themselves. So the contact person is allowed to I guess, hold the medication in transit from us. So just to clarify, so the contact person is able to collect it from us, or we can provide it to the contact person if we can't provide it directly to the patient for whatever reason, and there may be some specific circumstances around that. But at this stage, we've yet to encounter that situation. They can have it as part of it, transiting the provision of the substance to the patient, but our legislation requires that once it's in the patient's possession, it needs to remain in their possession. So certainly we've had a number of our patients, like Alice and Scott have said, in terms of our activity, it's been much higher than we originally expected. So we've had a number of patients in, hospital settings. So we've worked with the hospitals to come up with an arrangement of how that can be, how the VAD substance can be stored such that it's secure, but also still in the possession of the patient.
Thanks. And that's a logistical question, which I know WACS has been working on. And obviously, Gareth, you would know as well from your experience as well, perhaps within the metro system. So that's a segue for you, Gareth. We'll bring you back into the fold now, after waiting so patiently in the wings, waiting to make the big spotlight. So Gareth, as I said, is a emergency physician working at Charlie Gardner's, and he's been providing VAD throughout some parts of the state. So perhaps, Gareth, thanks for telling us a bit about your part of the story.
Yeah, indeed. Thanks. Thanks very much. So good evening, everyone. I'm Gareth, as already said. I'm an emergency physician and toxicologist from Sir Charles Gardner. It's pretty safe to say that my work with patients in this space has been a bit of a change of scene from the chaos of ED. I've seen about 50 patients thus far for assessments and walked the majority of them through their process as their coordinating practitioner. Most of my patients have been in Perth, but I have had some country patients, so from Port Hedland, Kalgoorlie to Albany. I've met people at home, in hospital, in aged care, and in all of these places I've sat with them, and in what is sometimes a relatively brief but very intense relationship, we've talked about all sorts of things. I've heard stories of intense suffering, of lives well lived and sometimes cut too short, of the difficulties in navigating a treatment treadmill that you can't see a way to get off. And all of these things have made me realise that this is not a choice between life and death. These are patients who are already dying and are strongly and repeatedly asking for assistance to die in the manner that they feel best suits them. People often have two questions for me when I talk about this. So what's it like, and what's the personal cost to you? Well, what's it like? I've seen a really large number of deaths before my involvement in this, and I've seen lots where there have been things left unsaid, and with both the patient and their family distressed and sometimes in pain. And I can say that this is the complete opposite. They've been surrounded by their closest family and on occasion up to 30 of their closest friends. Universally, they've been surrounded by love, and most importantly, it's been exactly how all of these patients have wanted. They've died well. What's the personal cost? Well, it's complicated. So for me to do this in the way that I think is right, you have to give a bit of yourself to each patient, which does come at a cost, both emotionally and in terms of figuring out how to fit this in with the rest of your life. But I'd say what I get back from this is very professionally satisfying. I genuinely walk away from this feeling that I've helped people, and that's something that my patients are giving me that's worth much more than what I'm giving them. So yeah, there's a cost, but there's a tremendous personal and professional gain. I won't attempt to speak for rural clinicians, seeing as I'm not one, but I think broadly there are a few additional challenges that I've encountered when I've seen rural patients. I don't need to tell you, WA is huge. Our law allows a few things that make the process a bit easier though. So we can see patients by telehealth, which is not allowed in Victoria, and certainly many remote assessments are undertaken this way. It's not perfect, but it goes a long way to reducing the restricted access that comes with living far from an available practitioner. The Regional Access Support Scheme, or RAS, functions well and makes it easy for metro practitioners like me to see patients in regional areas. Many regional practitioners I've spoken to have had concerns about being the sole VAD provider in an area, and that this will end up being an unacceptable burden on them. I think that's a really reasonable worry, but I'd just like to reassure you that we are all here to help out, and we will happily share the load with you. Just as I'm not expected to see every VAD patient at Charlie's, regional practitioners cannot be expected to see every patient in their region or even within their practice. We have a network of involved clinicians called the Community of Practice, which continues to mature. Our vision is broad representation at the leadership level, including specific rural leads, not to take over any role that WACS or Rural Health West are trying to undertake on a system level, but to make sure on the individual provider level that adequate support is able to be given. Undertaking all of the firsts that occur, as well as trying to fit VAD work alongside usual work as you reach a degree of familiarity with the process, all require support, and our aim is to have a broad group of colleagues that allows meaningful peer relationships to develop, even across the vast distances of our state. Remuneration is an ongoing issue, and the RAS payments for an attendance are very reasonable, I'll tell you that, including time taken for travel, but Medicare sits sorely behind, which is an ongoing bone of contention with lots of my metro colleagues. Medicare payments are specifically prohibited for attending for administration, and both schemes, although the payments with the RAS are much better, both schemes don't account for non-patient facing time, which in some instances can be quite lengthy. My best estimate is that an uncomplicated path from first request to certification of death takes on average 12 hours, with only 4 to 6 of those hours patient facing, and only 2 hours or so eligible for Medicare rebates. So with that as the downside, it's really valuable work. It's probably the most rewarding work that I've done in a very long time, probably ever. And I look forward to answering any questions that you have. And if you have any future questions after this, feel free to reach out. You can Google me and find me easily enough, or on the global internet.
Thanks, Gareth. A direct question from Lucia. Hi, Lucia, to the northwest. How long does it take for one of us, on average, to go through VAD training? She has a patient who's made their first request to her, and she's in the process but hasn't done the training. Would it be faster to direct the patient to one of the existing providers? In other words, is it possible to get through the training in time before the patient runs out of options? Thanks.
It's very legitimate to accept a first request on the basis that you're going to complete training. It's specifically covered, and it's very legitimate to do that. And I think there's a benefit to the patient in having a provider that knows them. I think that's a really unique situation that I don't really, as you can imagine, I don't get the opportunity to be involved in. Having said that, how long does it take to get through the training? They'll tell you that it's an estimated sort of 6 to 8 hours. And I think it really depends on how much time you have. There is an assessment at the end which you're required to get a very high pass mark on. And so I think My take on it is easier to do all of the training in one go, or as close to one go as you can, because it makes doing the assessment at the end a lot easier. And it's like, as with any bit of mandatory training that you will do, or any bit of training, there's the other end of it. You know, once you complete that, there's still things that you won't cover. The training's been made as short as it can reasonably be. So approximately 6 to 8 hours. There are opportunities if you're ever down in Perth. There are some, the hospital networks are definitely running training days where I guess you could apply for, so we're encouraging people within Metro to apply for professional development leave to attend a training day, where you have a day, you'll meet other people doing the training, and you can, you know, it's a lot easier to sit through training when you're with a group of people who are also sitting through training. But obviously I realise that the logistics of distance make it hard.
Thanks, Gareth. I think that's a really valid point, particularly for our Northwest and Kimberley people working on salary who have time available within the contracts for upskilling and for further professional training. And it's a matter then of talking with your regional medical director and getting the approval, finding out when the courses are, and then getting the approval to go. And just as an aside, if you do have any problems with that, please let me know directly in my wax role as GP lead, and I will create undue influence as required. Or due influence as required. So please, if you're having difficulties getting education leave to do something like this, please let us know, or let me know, and we can talk to the people. Team, we've done just about exactly the 1 hour that we'd forecast, and we apologise for the delay in starting tonight. As always, the gremlins have got in before us, but we were able to control their little activities and get this to you with everybody present. Are there any further questions? Because I haven't seen any come up since the seers. So if there are any others, we can answer them. If not, please send them through to Rural Health West to Kate and Kate Chetron, who sent you the invitation, and we will then pass on to the team through our collective emails and endeavour to put some answers up on the website for you, which will be the easiest thing to do. There will be this has been recorded for you and for your colleagues, so that those who couldn't get here tonight for whatever reason will be able to watch it and learn what we have from our great presenters. So once again, Scott, thank you for your insight and for your knowledge and the enormous amount of work that you've done in getting this process on the road, and for sharing with us the concept of the enormous effort that was involved in getting this into place, and also some of the details of what it's like to continuing working in this area. And Alice, we stand in awe of your team and for your positive focus on behalf of the patient rather than on behalf of the system. And we know that that militates against some aspects of the public service structure, but we hope that you're able to keep that ethos into the future, and we'll support you as best we can to do that. So thank you for providing that very clear insight into how we can find out what we need to know and from whom, and that there is an avenue that we can go to get the information that we need to look after our patients. Fiona, your experience in Albany was both enriching and delightful, and it's a wonderful example that you've chosen to us of the complexity and the depth of feeling and personal involvement involved for all that were looking after that person. And we know that that's just an example of the many others that you've done, and we can all grow our own bank of experiences of people that we've looked after in this sphere and in palliative care. So thank you for showing us a model of how that is done to its best. So thank you for that. And for providing the service. Brenda, and thank you so much for letting us know about what happens at the pharmacy level and reminding us of the legislation bit around the secrecy, but also matching that the availability for us for the process, the relative ease of availability, and also the mechanics of accessing, administering, or accessing, storing, administering, and cleaning up of the materials involved. So thank you for making that so clear for us tonight. And Gareth, thanks for your wonderful first-hand experience of so many encounters. And it's somewhat of a paradox to have an emergency physician involved with end-of-life care. It's like the Bronco rider who likes riding dressage. We want to thank you for sharing that strength of that breadth of experience across the state, and particularly at the personal level for your willingness to go outside your department and travel and look after people in spheres outside your immediate department. And that's a sentiment that I think all of us in rural areas admire, and we enjoy that level of professional participation and generosity. And thank you for sharing about the mechanics of, but also not the mechanics, but also the depth of feeling that's involved for all of us working in this process. Because it's not a sterile experience. No, there's no way that it can become a sterile experience at the emotional level. This is deeply moving and deeply confronting at the personal level, but it's also deeply moving and enriching at the same level. And that's the paradox of this sort of work. And I think all of you that have presented tonight have exemplified that. And we can continue to enjoy it where we have, or aspire to enjoying that when we're yet to do that. So thank you all. And I don't know if we need any round the table goodbyes, but I guess we can all do the current video thing and wave to a goodbye to the audience. And thank you for participating and for the questions that you've all given us. So
sorry,
we'll
we do have one
now.
last question.
Last question, thank you.
Alice. Alice, can you explain the significance of the tree behind you? A few people have come through and asked.
This is the thanks, we're still last.
Oh, well. So our team in our early days really wanted to find a way that we could safely hold the people that we've cared for, somewhere where we can remember them and keep them safe. So it was a bit of a combined effort. I trolled some parks to find some branches. That idea was inspired by Nikki, our social worker. Kim, who's one of our nurses, came up with the idea of tying ribbons on the tree, and that they would be varied and different as the people are. So the staff can choose something that they feel represents the person, and you won't be able to see them, but some of them have leaves on where the guys write the person's name and maybe the year that they were born and the year that they died. Sometimes they draw things on the ribbons. So had a very passionate Eagles supporter. He's got a yellow and blue ribbon tied together with the logo on. A gold miner who's got some gold stitching on his. So different things to give us a bit of a space to really remember the incredible people we've cared for, regardless of whether or not they go the whole way through the process. They're all people to us, and I think this is our way of keeping them with us.
Thanks, Alice. And so I hope that we've covered the list of questions. So Douglas, I hope we've covered the list of questions that you had. Had the contact points, we've covered the Navigator, we've certainly met, and the team, and the eligibility, that's covered as well, and the Navigator team can help us decipher that. And then how do the patients contact the Navigator? Again, that's all been answered. So I had left your question to last, Sue, because it covered so much of what we were going to be talking about tonight, and I hope that has answered it. And Alice, thank you for sharing the meaning of the tree, and it's a lovely thought, and it's quite symbolic. And so we, in this case, it's the tree of life, but it's a transition of life, isn't it? So it's the TTL, the tree of transition of life, rather than the tree of life. So thank you very much, everybody, for your interest and participation and for your questions tonight. And team, thank you for your presentations, for making the time available for our colleagues. And it's over to you, and it's good night from me.
Good night.